thank you very much for this very, very kind invitation. It's really a pleasure for me being here and share some of the challenges we have to face at a hospital laboratory, mainly in Germany. I also have some insights in other European settings. There, I would like to start with the disclosure. Then almost all of that was already said about me myself, so we can switch that. We will talk about a little bit about the German healthcare system in the beginning, just to get an idea how the system itself is set up. Brief view on the different European healthcare systems or the impact of these. Then specifically laboratories in Germany, how they are organized. And then we start with the challenges we have there. So I will address today two major challenges we have there at the moment. One is staff shortage, especially for the technical field, and then economic challenges combined with reimbursement and the different reimbursement strategies there. And then afterwards, I want to show some strategies for higher efficiency in-lab testing in combination with the clinicians, the so-called demand management, and then we'll finally go from a vision for laboratory medicine to the conclusion. So let's start with the German healthcare system, just to understand how it works. Germany itself is a federal state like the United States. Healthcare in Germany is mainly organized on a state level. So all the medical services and issues are planned on the state level. So how many hospitals should be there that need to be approved by the state, as well as other aspects like getting reimbursed, ambulance doctors, all these things are organized on a state level. Just reimbursement, how much do you get for what kind of service, and financing all the whole system is more or less organized on the federal laws. The system itself is divided. And that's a difference to the laser pointer. That's the difference to most of other systems worldwide. It's in former times completely divided sectors: the ambulance sector and the hospital sector. The ambulance sector contains of over 160,000 ambulance doctors. They are organized in self-administration of these ambulance doctors. So self-administration means that the whole organization is run by doctors. This is from the state-driven healthcare system during the Third Reich created this tremendous negative effects. So when this was all set up after World War II, it was absolutely clear that politics has no role in setting up the healthcare system. Therefore, healthcare is organized in a self-administration in Germany. If you want to deliver medical services as an ambulance doctor in Germany, you need to get a permission, and that's this KV, that this is the self-administration who gives the admission to ambulance doctors. You have to apply for it, otherwise you're not getting reimbursed for public insured people. The other sector, the hospital sector, is also quite interesting because the number itself, 1,800 hospitals in Germany, doesn't seem so big, but if you convert that into hospital beds per 100,000 inhabitants, you see here on the right, we are number 3 in the world after Korea and Japan. Only Korea and Japan have per capita more hospital beds. So we have a lot of hospitals, and hospital costs money, so therefore that's kind of a problem we have there at the moment. I just have for you some comparisons to the United States, just to make that a little bit more clear. The first line here is just the country area. You see the United States is about 30 times bigger than Germany. About 4 times more inhabitants are living in the United States than in Germany. About 3 times more hospitals are there in the United States than in Germany. So comparing to the inhabitants, a lower factor. But what you see here is the proportion of ambulant and patients which need to stay into the hospital for a few days is completely different, because there this switches from 3 times more hospitals to 0.3 as a factor. So much more ambulant services are done in the United States than they are done in Germany. And to see if the system as a KPI for the quality of healthcare systems, you see that life expectancy is almost the same. It's a little bit higher in Germany, but not really that big difference. So even if there are less hospitals, so hospitals, obviously the number of hospital beds per inhabitants are not directly connected to these KPIs of healthcare. The next insert here is the reimbursement system in the beginning. We'll come to specific reimbursement later, but just to show you the principle of reimbursement, we talked about these 2 sectors, ambulant and hospital sectors already. And then we have the insurance status of the people as another dimension, where about 90% of all people are public insured. Everybody is insured in Germany. There's no possibility to be uninsured in Germany. So 90% are public insured. 10%, if they earn more money than a certain cutoff, are eligible for private insurance. So you have for every of these 4 fields a different reimbursement system. So sounds a little bit complex. In practice, actually, it is kind of complex because they are conferring to different lists. We have the EBM, so-called Einheitlicher Bewertungsmaßstab. That's a list of all medical services that is always updated by self-administered committee, and only services which are on this list can be reimbursed. So if you have some new test, you have to wait until these are on the list, then you get money for this for 90% of the patients in the ambulant sector. And the private ambulant ones here, there's also tariff lists responsible for that. That list is called GOA, Gebührenordnung für Ärzte. That's a very, very old one, decades old, never updated. But there you have the possibility. So, for example, there even troponin is not listed there, so you get an idea how old that list is. But you can get reimbursement via analogy. So you can say, troponin, for example, we get reimbursed by some old hormone tests. We say, okay, that's quite the same test. So that's how we get money for troponin. If you now go to the hospital section, you don't get money for a single test at all. The hospital gets the money based on the DRG. DRG stands for Diagnosed Related Group, and only the disease of the patient is triggering the reimbursement. So if you have a myocardial infarction and you treat this patient with 3 troponin tests, or you treat that with 20 troponin tests, you get exactly the same. The hospital gets the same money, and the hospital runs the lab and gives a certain amount of money to the lab, but not depending on the patient they have there. And if you have private patient, then the private insurance company also pays this DRG, exactly the same like they get for the public insured, but additionally they get the GOA prices on top for these patients here, and if private patients are into the hospital. Here just small some explanation about the EBM catalog again, that regulates the reimbursement of services in the public outpatient sector, updated once a quarter, so 4 times a year. New codes, modifications of old ones, or tariffs can be implemented following the decision of this evaluation committee. That's one of the self-administered committee during the year. We know that IVD tests in Germany have seen both payment increase and reductions as the federal government realigns budget and health priorities. So even if that's self-administered, the government set up some kind of priorities, and the self-administration reacts there based on that. What's important is this, what I have there in red on the bottom. What gets on that list? It's all based on scientific studies. So new treatments need to be superior to existing treatments in medical effects, proven by studies, to get reimbursed better than the old ones. So the basic idea behind that is reimbursement is driven by science, not by industry. And if you now look at the hospital system, and in theory, we were all now talking about this yellow pick here. These are the costs financed by for the patients, so for the patient treatment. These are just the running costs. These should be covered by the insurance. All the investments, so new buildings, new instruments, all these things should be covered by the state. So that's the theory. It's 50-50 in theory. Real life for years now looks completely different. There's running costs by the insurances, but the state does pay it depends on the state. In Germany, it pays for the hospitals between nothing and 40%. So we have, in the end, a completely underfinanced hospital system. Therefore, most of the hospitals in Germany have red numbers, and some of them even got bankrupt in the last years. So, for the different systems in Europe, I have that table, just the table with me. That's a table which is put in together by a friend of mine, which friendly gave that to me, Carla Krivet. And what you see here, that's a comparison. You have here Germany. I would like to start with, from my opinion, relatively good KPI there. Health expenditures per capita. So this means per capita, not per insured capita, but per capita inhabitants. You have Germany is the second expensive hospital system in the world, with $6,500 per capita per year in the numbers of 2022. Only your system is more expensive. What they brought up in this table, I think it's quite interesting, because you see there are some aspects like access to care, affordability, timeliness. There we are doing quite okay. We are also good in the sense of equity to that system, because there are no services in Germany somebody would not get. Also, public insured people get every medical service they need. But if you look at the processes, these are, we are one of the last ones here. And there are other European systems which do much better. And as we already said, that we have in Scandinavia, for example, Norway is one of these examples, or it's not Scandinavia, but also Middle Europe. The Netherlands are doing much better into these organizing a healthcare system, and the costs are even lower here with about $6,000 a year per capita. So therefore, I think that table is quite interesting to look at and shows a little bit the differences of the different systems. Let's go to the laboratory environment in Germany. How is our laboratory organized there? We have mainly two different areas, the hospital labs and the private labs. I put in bracket chains because more than 70% of the private lab market belong to 5 big international lab chains. So that's not only German one, they're really international operating lab chains. The number is approximately comparable, 350 in the hospital labs and 390 as the private labs. But the 350 hospitals are only these hospital labs which have at least one medical doctor in the lab. There are over 1,000 hospital labs run by private lab chains, so this is kind of a cooperation there between the hospital and the lab chains. That are mainly the smaller hospitals. As you probably still have in mind, we have about 1,800 hospitals in total, so therefore there are about 400 to 500 hospitals left which don't have any laboratory, which have all the services provided by a private lab, which is not inside this hospital. The doctors are about 670 in hospital labs and almost double the number at private labs. The hospitals are different, so we have low to medium numbers of samples every day, up to 3,000 samples a day in hospital labs, and the private labs usually have much more, up to 15,000 samples a day. Interestingly, and we will come afterwards also to that, that specialty testing is a little bit different. Of course, we need to provide all the routine testing into a hospital lab. The bigger the hospital lab is and the bigger the hospital is, the more specialties are tested there. The private labs mainly focus on specialty testing because of reimbursement. We will see afterwards that reimbursement for the routine tests is not so high, so that you can money from that. You will lose money if you do just routine testing. Another aspect here, just the economic aspect, general economic aspect of hospital labs. This is the number of people working in medical labs, and you see that is an increasing number from 2012 until 2022. So there are many people working in medical laboratories. So it's from an economic point of view, medical laboratories are really important. And what you see here, what I always mention, due to the reimbursement, the numbers of specialty tests in these private labs are continuously increasing because they always try to find something what they can test more just to make more money. Is it necessary to have a laboratory in a hospital? As I said, there are already some hospitals out there without a laboratory. Obviously not really mandatory, but you have to provide some kind of services, basic laboratory 24/7 services, including transfusion medicine and transfusion medicine as a mandatory structure. But for smaller hospitals without complex intensive care units, that there is absolutely mandatory to have a real laboratory on site. You can, for the smaller ones which don't provide these complex services, a cooperation with bigger hospital labs or private labs is also possible. There are very strict requirements for running a lab in Germany. I just picked out two aspects. One of these aspects is staff. The technical staff working at the laboratory is very fixed link to the education of a medical technician. That's a very fixed education. There's even a medical technician regulation. That's a law there, which says that most of the tests done in a medical laboratory needs to be done by a trained medical technician. There's a 3-year training there. So that's kind of an activity reservation for these jobs there. And you need to have a real medical doctor, because there are other kinds of doctors out there, but a medical doctor need to be there with a specialization for laboratory medicine to get these tests reimbursed. You can run a lab without a medical doctor, but then you don't get reimbursement for these tests. The second aspect besides staff is quality. There is for every laboratory, even if it's this very, very small laboratory as a ambulatory doctor's place, there is a strict regulation on that. So it's called RELIBEC, Richtlinie der Bundesärztekammer. That's a set of quality assurance guidelines by another self-administration, the German Medical Association for Medical Laboratories. It ensures the reliability, safety, and accuracy for laboratory diagnostics, and is absolutely legally binding. So you have to have that. Without that, you are not allowed to do any lab testing. What's in there? I just picked out two different aspects. One is, for example, internal and external quality control. You have to perform for all of the routine tests twice every day internal quality controls, and need to participate in external quality assurance every 6 months at a minimum. And the passing criteria of that are also fixed. This is how this table looks like. Just as an example, here you have the bilirubin. You have the limits for the internal quality control, plus minus 13% for bilirubin. And for the external quality control is plus minus 22%. If you don't meet these criteria, you're not allowed to do this testing anymore. The second one is compliance with standards. The guidelines align with the new European IVD regulation and the ISA standards, our lab ISA standard 15189. And the IVDR is something where the European Commission tried to copy Euro FDA regulation, but making it even stricter. It was okay, American regulation seems to be good, but we can do it even stricter. So this will cause a lot of problem. They just started with them, that they postponed part of that because, for example, of LDT tests, which will be almost impossible to perform in the future if this will take in place as it is there now. But the RELIBEC itself aims to standardize laboratory practices across Germany, ensuring high-quality diagnostic results and patient safety for all laboratory tests. The first aspect of the challenges there I want to share with you is staff shortage. The status quo in all medical laboratories, actually not only in Germany but in Europe, is that of course we need human workforce at the clinical laboratory. That's essential. And we observe an increasing age of these workforces, and that needs that with an increasing age of people working there, we have an increasing health issues of that staff. And on the other hand, we have a new generation coming there, generation Z and Alpha, and it's not so easy to convince them to work at night or on the weekend. So 24/7 shift plans are very difficult for them. So therefore, we also need to address that if we want to run it. Of course, we would like to do it like we did it in the past, but we need to listen to these people working in the laboratory if we want to have some kind of staff tomorrow working there. So what's necessary to do? We need to look if we can do the same work physically easier. We try to think if we can do it with less night and weekend shifts, and we can look for a more modern requirement environment at work. How that is possible? One possible thing can be automation. So I just have a few slides about automation. What is automation in a human laboratory? It's not the substitution of human beings. So nobody will be substituted by some technical solution. It's just the minimizing of human intervention to make the work more easy and more attractive for the people working there. How does this look like into a laboratory? I just brought up some ideas here. One of the things is software, including AI, that is kind of improving manual processes and support people working at the laboratory. Then you have robotic solutions there. And all of the things I'm showing you here are not future visions. They are already in place there. On the left, you see moving robots. These are small robots just strolling around in the laboratory. The easier one can they carry samples from one room to another. But there are also more fancy ones which can take over manual steps, like, for example, even loading samples and reagents to instruments. They are already there on the market. That's already possible. What's more reliable and from a certain point of view even more attractive are these fixed robotic solutions. You see here this Roche instrument here and some other instruments over there. There's the robotic arm, and the robotic arm, it's just moving forwards and backwards and doing all the manual step a lab technician would do in this small laboratory. This solution is able to operate without any staff up to 16 hours. And there are many hospital laboratories already. I think at the moment these are 5 in Germany, which have skipped all night shifts with these kind of instruments. So there's nobody on site as a lab technicians during the night. So what I said, we were able to get rid of night shifts, not to substitute the workforce, the human beings, but to make the work more attractive to this new generation. The bigger and probably most expensive solutions are these track solution, total lab automation. You're, of course, aware of that. The positive effects of that is that you have a standardizing of processes, a reduction of errors, but you also implement a single point of failure with these systems. Their backup solutions are sometimes difficult, and what's from a hospital point of view also very important to really look for good stat processes, because many of these systems originally say that stat processes are not possible on that system. You need to have a manual steps in between, for example, manual centrifuging and these things to really have these samples fast processed. It depends. It needs to have a look at that. You can set it up also automatically, but it's worth looking on that issue. Many of the laboratories failed in that aspect. Let's come to the next challenge, economic challenge, as I already told you about reimbursement. I just put together some information about reimbursement in different European countries. I just wrote a mail to different colleagues there and asked, can you explain me your reimbursement system? It was quite interesting to see all these answers, because sometimes it's really hard to understand if you're not living in that country. I tried to put that a little bit together here. Germany, we already talked about that. So 3 different systems, we already had that. UK have at minimum 2 different systems. You have the NHS system and private labs, private hospitals there. NHS is like in Ireland, no money at all for specific tests in the hospital for hospital labs. There's just a budget. Laboratories get a budget. They have to test everything what is ordered, and hopefully they can come along with the budget. Italy, it's probably one of the most interesting ones, because they really get just the same reimbursement, very strict, very easy. Same reimbursement for a sodium, they get a certain amount of money no matter where the patient or the sample comes from. If it comes from a hospital, it comes from an eminent person, so very easy to work with that. Switzerland is kind of similar to Germany, but is in the ambulance sector just one reimbursement. There's a difference, but they also have the DRG system in Switzerland for the hospital patients. What I did now, just to put together for not only what gets reimbursement, but also to show you a little bit how much a test costs, to get an impression from economic point of view, how much does it cost. I have the reagent cost, and that's something what I'm estimated from some contracts. I know these are not precise numbers because contracts are secret and nobody of us is allowed to talk about that, but that's about the dimension, what paper tests contracts look like in Germany. And I have the total costs by adding all costs of the laboratory you have there, including staff and all the things you have, divided by this kind of points test is created. So therefore you have an overall cost per test in the end. This is how it looks like. I transferred that all into US dollars. So that's not different currencies. That's all converted into US dollars. For sodium, for example, it is about 5 cents. The total costs we have there are about 40 cents. ASTs, liver enzymes, also 5 cents of costs, 56 cents of total costs. Red blood cell count, 20 cents of reagent costs, 80 cents total costs. And up to molecular testing here for SARS-CoV-2. That's about for point of care cartridge here. That's about $30 per reagent, and total costs approximately the same with 34. And if we now look now to the reimbursement of different European countries. We start with the first two German ones, so the public reimbursement of the EBM and the private of the GOA system. And you see here the difference for sodium, 26 cents for sodium, and for a public patient, public insured patient, private insured, €2. So you have between 5 to 10 times more in for private insured patient there. What you see, if you go down here, you see that the more these tests come to specialty testing, the higher the reimbursement. And that's the reason why all the private labs focus more and more on specialty testing, because that's the way how they can make money with. The other ones they need to offer, but they spend money on that. They are not making money with that, so they try to always minimize the routine testing and maximize the specialty testing. In Italy and all the other countries, you see they are pretty much comparable to the German private system here. We are quite in line with the private system with the other European countries, but much below that for 90% of our patients. And now if we compare that to the total costs I showed you above here, you see that for all routine tests, so sodium AST, RBC, and coagulation PTT, we pay more than we get reimbursed for ambulant patient. So that is the reason why this always needs to be a mixed calculation. Inside the hospital, as I already said, we don't care about these reimbursement because we don't get any reimbursement at all. We come to that later. So economic challenges for outpatient. All countries reimburse tests somehow, except UK and Ireland, reimburse tests for outpatients. Different insurance system leads to different reimbursements. Tariffs are very different over Europe. Majority of countries, the reimbursement covers the cost. Actually, it's only in Germany where you don't have the ability to cover the cost for routine testing. And some countries, for example, Germany, do not cover these costs. So the mixed economic calculation is necessary. How does it look for hospital patients? Also different. Some countries reimburse also the tests for inpatient there. Also different insurance systems, of course. Tariffs are also very different over Europe. A lot of countries but have no specific reimbursement for lab tests because of this payment via these DRG systems. What does this mean? If tests are not directly reimbursed from economic point of view, as somebody who's running a hospital, there is necessary to have relevant strategies for optimizing, especially minimizing lab test ordering, because the fewer tests you order, the more money you have left afterwards. So therefore, there need to be saying, is that possible? That brings me to the next aspect, strategies for higher efficiency and demand management. How can hospitals face these economic challenges? So what is that? Optimizing that in the sense of a good patient treatment means optimizing the appropriateness of these lab tests. So only lab tests which are necessary for the patients are sensible. Inappropriate tests are tests which has no effect on the treatment of patient. And that's an interesting publication here. Concerning solutions, clinicians were asked, what do you think, what could be good solutions? And the clinician's view says it depends on the training. Residents generally recommended educational intervention, where specialists tended to favor technical solutions such as lockouts. In this publication, there were, I don't know if that's readable, but you have here the blue dots were the communication aspect, so creating awareness, reflecting consequences, conferring with peers, and feedback on the amount of testing. So that's all about communication between the laboratory and the physicians. Has a positive effect on appropriateness, more supervision by specialists and feedback and training by clinical pathologists, and education are the educational aspects, and pop-ups and automatic lockouts are the technical aspects which were in favor of the specialists there. Another, in my opinion, very helpful idea is just to following guidelines. So choosing wisely as one of in my opinion, very, very helpful guidelines here. I always pick out one example for the pre-surgical lab tests, and that's absolutely clear. Took the choosing wisely. We have many literature out there from different societies. We say exactly the same all over the world. Don't obtain basal laboratory studies on patients without significant systemic diseases undergoing low-risk surgery. And this means just non-lab testing, not any test. That is the strong recommendation there, and it's very hard to bring that in place into a hospital, but I'm also working on that, and this in the end will lead to a more higher appropriateness here. Here you see an effect of a friend of ours who did that in Salzburg. They found that they had troponin and NT-proBNP in lab test panels there. They discussed that with a cardiologist and just throw them out of the panel and said, okay, you need to order them specifically for the patient. And you see here at these time points A, B, C, and D, when they started that, how dramatically the numbers of ordered tests dropped. And the important thing of that study is that here they also monitored the clinical effect for the patient, because not ordering tests can probably have also a negative effect on the patient treatments, and they monitored that and said there was absolutely no effect on the patient treatments. And that goes so far that you have also AI possibilities here. Here's the clinical decision support system based on AI to identify neonatal sepsis. Why I put out that one here is because that's really old, that's over 10 years old, and you see that's not something new and fancy, that's really out there for quite a long time. So it's really time for us to adopt these things to make things better. In over 10 years ago, and this study showed that outperformed all other strategies which were in place before that system. So, to the vision there, what is necessary for hospital labs to survive in the future in Germany and Europe? Ambulancization and decreased length of stay demands faster turnaround times. We just need to deliver our results faster. We need to optimize our reporting, so ambulant and hybrid patients need a concluding report. As talked about these two sectors, if we want to provide good services, we need to combine these things. It's important to create lab reports where you can compare lab results from different labs. We are working on that, on an electronic reporting system also in Germany at the moment. And I think because of that, hospital labs can have an increased relevance because they are probably the points where all these things come together for the relevant diseases. That's the only slide about pre-analytics. That's very rare in my presentations, but pre-analytic I think is a very, very important issue also in the future because the main topic in pre-analytic is garbage in, garbage out. And if we get a result which the clinicians cannot work with, that means we need to redo the testing if the test result is necessary, but we have less time for redoing these blood tests. So therefore, the pre-analytic needs to be perfect in the first run already. And also in pre-analytics, cooperation between laboratories is very important because not all tests are done into one laboratory. Samples are sent from one laboratory to the other one. We really need to rely on the quality of the pre-analytics if we got samples from another lab. So cooperation also on that aspect is very important. Lab consultation, including AI, is something what's an oncoming issue for sure. Here that's a publication which displayed a few applications in clinical chemistry, and it says novel application including uses in laboratory results, diagnosis and risk prediction may transform the role of the clinical chemistry laboratory. I think that's very important because we all need to be aware of that. We are in the middle of a development here. And that's, I think it's very important to identify our role. Potential savings through AI was quite an interesting slide for me. And there it says, okay, the laboratories have very high potential here of savings. So we are probably the first one who should start with implementing AI in our laboratories. So let me come to the conclusion in the end. The main the main take-home messages for today from my point of view is our field, laboratory medicine, is really a visionary field. We are one of the driving fields in medicine, and we should always be aware of that. A high-functional laboratory will always be mandatory for good patient treatment. There won't be good patient treatment of clinicians without good laboratories. Over 70% of all diagnoses are based on our results. In worldwide, there are countries where saving in the area of laboratory testing is still possible, but as I showed you in the public insured sector in Germany, there are some countries which are already working really on an economic limit there. But what I always like to encourage everybody, if we start and think about optimization, the showing for the potential is not also economic potential. It's not charging somebody more because that's sometimes not even possible. We really need to optimize the processes. That means our processes in the laboratory, but also the interfaces, the interaction with the clinicians to optimize the treatments. And finally, if we all do our homework, we will both benefit. Both would mean here we as healthcare professionals at all together, and what's most important for all of us, because that's why we are doing our job, that's our main motivation, the patient. And finally, at the last slide, I saw today very nice view of our laboratory outside here to the water and Mount Rainier. We also have something what's really nice to see. You see here in this end, this is our hospital over there, and we look outside, we see this picture here. That's the summer castle of the Bavarian, the former Bavarian king in that times. So, like you have it here, we also have a nice environment to work at. Very proud to be there. Thank you for your attention. Yeah.
Thanks, Alex. That was great. One of the hallmarks of American healthcare is that we have to argue with insurance companies. With 90% people publicly insured, do you find that you have to argue with the to get payment? For example, do you have to seek pre-authorization for expensive tests?
Usually not. So we don't have any contact for the public insured patients because we don't get any reimbursement for them for the hospital patients. What we have is there is a special opportunity for example, genetic testing, because ambulatory doctors have only a certain amount of money per patient to spend on lab testing. And there are some of these, so they have a certain budget for each patient. And some tests are allowed to order outside this budget, for example, genetic tests. So therefore, for some specialties, it was made easier to get reimbursement there. The discussion about billing there, we have only with private insurance companies. And there, this is not so often, but sometimes there, because there's in this GOA, there are some special sections, what is allowed and what is not allowed. And some of these insurance companies, they also started using AI. So when you when you send your bill, or the patient sent the bill to the insurance companies, it runs through an AI system, and it says, okay, just send it back, there's something wrong, then we need to start arguing with this insurance company. Usually we get paid afterwards, but it's just a little work, additional work we have to do.
One of the things here in the U.S. is the hospitals collaborating into larger chains. Is that something that you see in Germany too, with smaller hospitals being bought up by larger hospitals, or maybe forming?
Yeah, in Germany there are you have four different kind of hospitals in Germany. You have university hospitals, you have community hospitals, you have hospitals run by some church organization like our hospital, and you have private hospitals. And private hospitals are buying community hospitals. So there are many cities which, because all of the hospitals, as I said, are running out of money, try to get rid of the hospitals, and some of them are then sold to private hospital chains. And these are pretty large chains there. And they are doing economically always better than all of the other ones, because they have just a main administration. And that's the big difference. So they just save a lot of money on the administrative side. But working there is not really fun.
So
yeah.
Given what you showed us about reimbursement, and that routine tests are really a loss, what do you see as the future for especially hospital labs?
I think we can, if we follow these strategies I showed you, I think we don't care about reimbursement in a hospital so much, and won't even care that probably even less in the future if we get enough money from the DRG system. If that's possible, that's fine. But we are not quite sure that this will be the case. And what will be what's important, because for example, you need to apply, as I mentioned before, that you need to apply the self-administration to get reimbursed for public insured patients. I also have the permission to measure samples of public insured ambulant people and get paid for that. That is at the moment a very, very rare amount of samples we have there. Just a few samples a day. With these development, and that's not really based on the reimbursement, that's based on the motivation to the higher grade of ambulantization there, we will have more samples from ambulant people. And so therefore, this part will be bigger. So all the reimbursement thing of the ambulant patients will play a much larger role in the future, because we want to do both. Because just to really provide lab services for the whole journey of a patient will mean that we will focus more on the ambulance side also. And that is the case for every hospital laboratory in Germany. Yeah.
I have a question about sort of overnight staffing or weekend staffing for just so I don't think of it as necessarily having easy automation solutions. So sampling insert platforms where you mentioned SARS-CoV-2, so the sampling insert cartridge, or I think about, hey, this is automatable, but Gram staining and stat DSF. But are those integrated into automated systems, or is there a sort of a skeleton crew overnight that forms a site? How?
At the moment, I don't know a system where that is already implemented. But from knowing how these systems work, there is, for example, if you have this big cartridge robotic system of Cepheid there, this is a system what can be theoretically handled by one of these moving robots. So it's just a matter of programming. So you need to have an instrument which kind of where you can kind of applicate these things for, and you need to have this robot. But the companies who are doing that are not the big companies for lab testing. These are smaller companies focusing on robotic solutions, and they are actually quite flexible and fast in solving these issues. Gram staining, I don't know. I think there's also, if you consider automatic, so semi-automatic solutions for gram staining, I think it's also possible to do that and integrate that.
I have an online question about that. One of the large expenses in the U.S. is administration and overhead for billing and for coding and costs associated with that. And do you know of any comparisons that take that into account, sort of in general for healthcare, but specifically for lab testing as well?
I don't have any numbers with me. That, of course, that's also, if you look at private labs, these are own departments. So into these private labs. So these are important areas, and you need resources to do that. But what's the big advantage is that we just have these two systems, and we know from the early beginning what system because with the order we know exactly if this is a private insured patient or is this public insured patient. So we know exactly how the bill will look like and who we will send the bill to, and that of course makes it much easier than without knowing what will be the right address for the bill and how much can I bill for that. And what's also interesting is that we at the moment having a project going on not only for lab test billing, but also for completely billing for the hospital to implement AI on that. Just AI who's scanning the patient records from the state, and then identifying and extracting the relevant procedures, and then converting that into a bill having all the necessary aspects in there. and we are quite sure that that is possible. That's not a 2-month project. That's probably a few years project, but it starts working, and then via improving, I think we will have that within a few years' time.